sometimes they start developing these very, very prolonged period of hypoxemia. And when the hypoxemia is very prolonged, they start accumulating carbon dioxide at the same time. So when they have this recurrent accumulation of hypoxemia, they slowly get increase in their average serum bicarbonate level, which leads to a blunted ventilatory response. In addition, these obese patients at daytime, because they are obese, they also have increased metabolic rate, where their lungs are not designed to meet this metabolic minute ventilation need. This again leads to daytime hypoxemia and chronic daytime hypercapnia. And finally, we have some understanding now that the peripheral leptin resistance also leads to blunted ventilatory response. So for these particular patients, when they have this blunted ventilatory response, eventually it results in chronic hypoventilation, which leads to chronic hypercapnia, and then all this together forms this particular vicious cycle. All this eventually, in terms of sleep medicine, resulted in this nocturnal apnea insensitivity. So on top of what we talked about in terms of OSA, these patients doesn't feel the need to breathe, even though they are not breathing. And this is when they get this central sleep apnea. Again, this is a typical tracing. Contrast to obstructive sleep apnea, you can see when the patient doesn't have the airflow, they don't feel the need to breathe at all. So they simply stop breathing. It is only when the CO2 or the CO2 have built high enough or the oxygen have dropped low enough, then they suddenly feel the need and they breathe again, a hypercapnic and then, a crescendo and then decrescendo type of breathing. And then finally, after they clear up some of the CO2, then they go into another cycle. So these are central sleep apnea. So obese patients do develop both obstructive and central. So all this, when we put them all together, these patients, in obese patients with daytime chronic hypoventilation and hypercapnia, and with central sleep apnea, 10% of them have pure central sleep apnea, whereas the majority of them have both overlap. So they both have OSA and central sleep apnea. And these, we call it obesity hypoventilation syndrome, or back in the very old day, Pickwickian syndrome. Now, this is difficult to treat, because when you have this complex sleep apnea, usually they present to us on the PSG with a lot of obstructive sleep apnea and a little bit of central. But once we start treating the obstructive sleep apnea as usual with the CPAP or a positive airway pressure, then when you treat it, then you start helping them clear the CO2. And because you're just helping them clear the CO2 in the daytime, then you push the CO2 below their apneic threshold. Also because they have this sedative use, etc., and also because daytime, when they're upright, they have all these atelectasis, of which when you use CPAP, sometimes you temporarily open and you stretch their lung receptor. All these leads to their tendency to go into apnea. So all in all, a simple diagram is that when you treat them with pure CPAP, the more you treat it, the more you abolish the anatomic tendency for upper airway obstruction in obstructive sleep, but the more you instabilize the ventilatory drive in central sleep apnea. So in these patients, a lot of them finally needs these very, very expensive, a lot more expensive machines, BiPAP machines. So again, I think for those that work in the hospital, I think you know them very well, but for the benefit of those that don't work in the hospital, BiPAP is a basically more expensive machine that gives you both an inspiratory pressure and an expiratory pressure, and it changes by a certain rate that you can set. So at least for these patients, when you set them on a BiPAP, then they can inspire, and then even though they forget to breathe, the machine would come to a certain time, change into expiratory pressure, and then they can start breathing. These are a lot more expensive, very difficult to titrate, a very, very big burden on our part, and sometimes it's not very titratable. Sometimes we cannot find a very comfortable pressure for the patient, no matter how hard we try. Again, similar pattern, does weight loss help?